we're going to talk a little bit about question strategies and how to approach different questions when you encounter them during the exam. So we'll talk you through our thought process when we see a question and some strategies we advise our students on during the question taking process. So common themes that you'll see in step 2 questions. So there are a few really important features. So the first is really, what is the next best step? And so often you'll have a patient come in with A, B, C, and D symptoms, right? They'll come in with a classic clinical presentation of something. And of course, it would be very easy for them to say, what's the diagnosis? But step 2 is all about what is actual clinical practice? How do I diagnose this? Or do I need to diagnose it? Do I have enough to diagnose it? Or do I just go ahead and treat it? Do I need a surgery? Do I medically manage this? What's sort of the algorithm there? And a lot of this just comes from doing a lot of questions and seeing it in real life. What is enough to actually diagnose someone with cholecystitis? And what do you do with cholecystitis? Can I just let them hang out? Do I have to take them to surgery? When do I have to take them to surgery? And sort of figuring out those steps is really the key of step 2. And so making sure you understand those decision points. Also, another big question that's asked is, what is the best diagnostic tool? So using the same example of cholecystitis, right? You'll have a patient come in, right upper quadrant pain, happens after eating, colicky in nature, all of the classic cholecystitis symptoms. Everyone's thinking, okay, it's cholecystitis. And then they'll ask you, what is the best diagnostic tool? What is the test that I use to diagnose this? And if you spend a lot of time in the emergency department, you might think, okay, well, a lot of people just get CTs and they see cholecystitis on the CT. But in reality, the actual best clinical test is right upper quadrant ultrasound, right? So making sure you know what is the most effective diagnostic tool. And this isn't about cost, this isn't about, minimal invasive, et cetera. These will be questions that are tested during your exams. We're going to talk a lot about visual diagnosis and diagnosis. So sometimes there will be just a straight up, what is the diagnosis? I think it's far less frequent than the first 2 questions. There will be some visual diagnosis. They're going to show you potentially some radiologic images in the setting of a clinical vignette and expect you to be able to make a diagnosis based off of that. Complications are a big one. So anyone who comes in with cardiac symptoms, those same things that were important before, what happens in 24 hours, what happens in a week, what happens in a month, knowing those complications and knowing what to look out for. Risk factors. So these are a little bit more of the epidemiologic questions, right? So this is going to be if someone has a history of diabetes and obesity and sleep apnea and 18 other things, which of them most predisposes them to having a cardiac event, right? So making sure you know a little bit about the epidemiology as well is going to be important. And then, of course, there will be some basic sciences, right? So the pharmacology, as we mentioned, the majority of that stuff will be from the psych that we talked about, knowing all of the mechanisms of actions of those drugs and what can happen in drug overdoses and some of the common therapeutics. And then also knowing some of the medications that you use for these drugs, or for these diseases, excuse me. And the pathophysiology, though much less tested than on step 1, may still come up on step 2. So just something to be aware of and keep an eye out for.
And, you don't need to reinvent the wheel. Use what you know. You've taken many standardized tests before, and you've taken, God knows how many other types of exams in your entire life. And if you've made it this far, you've done really well on them, and you're an expert test taker in a lot of ways. So ask yourself, what worked on MCAT step 1 shelf exam? Maybe what didn't work? Maybe you had one exam that just didn't go well and you still think about that. Really try to not pass judgment, but think about what went well on that exam. What was it that was the problem? Was it more my mental state in leading up to the exam? Was it something on the day? Did I not include enough of this type of material? Did I not do enough practice questions? Did I do too many questions but didn't read the answer explanations? What worked and what didn't? So make sure you think about your overall strategy, what worked and what didn't, but also very specifically for each individual question, what has worked in the past. At the same time, of course, be open to other strategies. So some tips that we'll suggest here, if you don't do it, maybe try these out, experiment with these a little bit. The practice questions are really your opportunity to do this. So what a lot of us like to do, and we'll go through this in real time on these next couple of questions, but start with the question being asked. And by that, I mean, you have the vignette, something period, something, something, something period, and then you have something, something question mark. So that's the question being asked. So start with that first before you sort of read all the other blurb before it. Some people will then read the answer choices. I tend to do that, where I'll go to that last question and then very quickly look at the answer choices, just so I have a sense of what they want me to focus on in the vignette and what I'm trying to differentiate among. Some people don't do that. And it's really up to you. Try different styles, try both of those ways and see which is more effective for you. But go back and then read the vignette and highlight intelligently. I think it's really hard when you're, panicking or feeling overwhelmed in a question to kind of highlight everything, but really think about, if I were kind of a crabby attending, and I just wanted the bare minimum, just tell me the important stuff. What would you highlight if you had to pick the important things to focus on? And practice this under timed conditions. So I think it's tempting to sort of do everything on tutor mode, or just do things tutor mode, but maybe never do, if you, let's say for some reason you weren't able to do a practice exam timed. It's easy to resist putting yourself under timed conditions because it's stressful. No one likes to do that. But try doing it. You don't have to do that for every question. You don't have to do that for all of your UWorld Pass, but make sure you do some questions where you're really under some time pressure and actively engaging those question strategies, and just approach every question the exact same way initially. What you start with, what you read next, what do you do then? I think that's going to be really helpful. Anything else, Anna, that you liked just broadly for question strategies?
Yeah, I think one of the best things that I've recommended to my students do is exactly what you just said, is starting with the question first, especially because sometimes you'll get a treat and it'll say, what is the mechanism of action of this drug or something? And the vignette is completely useless and you don't need to even look at it. So it's certainly helpful to use your time wisely in cases like that. The other thing I'll say is, just in general, during the exam, you're going to get questions that are slam dunks, and you're going to get questions that are like, I have no idea, I've never seen anything like this. And to really just be judicious about your time and say, okay, I could spend 10 minutes trying to figure this out, or I could get 5 more questions right. So just move on. If you don't know it, just move on, and just be very okay with that, because I think that, getting caught up in questions can sometimes sort of slow you down long term. And it also sort of bogs you down, and you keep thinking about that question for questions to come. So just really try and be smart about how you're using your mental energy. All right, and so with that, we will go into some practice questions. So you'll see a little bit of each of our styles and how we go through it. And so I would start by saying, we'll look at the question first. So, which of the following is a predisposing factor for this patient's condition? And so I would encourage all of you to, as we sort of go through this, please feel free to throw out your answers in the chat, and I'll sort of give you my stream of consciousness as I work through this question, but feel free to put your thoughts in here as well. So 41-year-old man. So before I do anything else, I think, okay, he's actually pretty young, right? 41 is pretty young to be coming in with any sort of anything. So I'm thinking, okay, young, maybe a slightly more, maybe genetic, maybe some sort of more serious presentation, but also not a child. So, okay, 41-year-old man presenting to the emergency department for general malaise. Okay, that could be anything, who knows? He has noticed a lot of swelling of his face, hands, scrotum, as well as uncharacteristically foamy urine. Okay, so this already is setting up in my mind a couple of things. So a lot of swelling could be a number of different pathologies, right? So swelling can be due to renal disease. Swelling can be due to hepatic disease. Swelling can be due to cardiac disease, right? So I don't necessarily know which of these it is just based off of that. But when I'm hearing uncharacteristically foamy urine, that's a little bit atypical, right? So when I think about cardiac disease, I think about, heart failure, so pitting edema, maybe some sort of history of MI, et cetera. But foamy urine is not really a typical presentation of that. And then what else did I say? So then liver disease. So liver disease can also, just through portal venous hypertension, lead to a lot of edema. But again, you would see some maybe symptoms of jaundice, yellow eyes, asterixis, pulmonary erythema, sort of the classic hepatic dysfunction markers. And then you think about, then the third thing that I really think about is renal disease, right? And so renal disease, particularly nephrotic disease, can result in a lot of swelling as well. And so foamy urine can go along with that. You'll know that patients can lose a lot of protein in their urine, and they lose a number of things, can lead to increased hypercoagulability because of loss of antithrombin, loss of immunoglobulins, which leads to a higher rate of infection. So a number of things can go along with that. So based on the swelling alone, I narrowed a little bit. And then based on the foamy urine, I narrowed a little bit more. So now I'm thinking in the nephrotic realm. And as a couple of you have already said, nephrotic syndrome, great, perfect. So you're thinking sort of along the same lines that I am. Past medical history is unknown. Okay, whatever. Denies tobacco use. Okay. And then drinks 2 to 3 beers on the weekend. So not an unusual amount of, not an egregious amount of alcohol. And then currently homeless. Okay, so the fact that they put in that he's homeless makes me think about what other risk factors he might have, if there may be any additional sort of socioeconomic factors that could predispose him. 24-hour urine collection reveals 4.5 grams of protein a day. Okay, so this fits with nephrotic, right? Actually, if I had honestly just kept on reading and got 4.5, I know it's nephrotic. Okay, so then we have a renal biopsy and results are shown. So now we have a histology image. So we'll walk through what this means and look at the actual image too. And the results are obtained. Which of the following is blah, blah, blah. Okay, so this is what I know. I know he has some type of nephrotic syndrome, right? I know that. The question is which nephrotic syndrome, right? So there are a number of nephrotic syndromes that could be contributing. I will say he's a little bit young, right? So that's one thing that I'm keeping in the back of my head. He's also homeless. That's really the only other risk factor that I have based on everything here. And so now I have the histology to go off of. And are there any things that jump out to you guys when you're looking at this histology? When I'm looking at it, so we're looking at a nephron here. And so I can see, so what I sort of see is this area of the nephron looks somewhat normal, right? So there's sort of this focal area here, which is a little bit more normal, not as pathologic, versus here you see sort of this, for lack of a better pathologic term, sort of more fluffy pink stuff in between all of the sort of loops here of the nephron. So you have this thickening of this tissue in sort of a focal, and if you'll play along with me here, and in segmental distribution, right? And so if you saw other nephrons, what you might see is sort of some segments have it, some segments don't, a little bit everywhere. So this makes me think of FSGS, right? Focal segmental glomerulosclerosis. And that fits with this sort of rapid onset progression, this 41-year-old, otherwise pretty healthy. And so now I've already gone a second step beyond the question, right? So I know that it's nephrotic. This next step takes me to FSGS. And then the third step is what's predisposing for FSGS. And so that is a little bit of just memorization. That's just knowing a little bit of the actual pathology and what comes back to the pathophysiology of the disease. So what I'll just tell you, because this is more of a memorization point, is that HIV is a predisposing factor for FSGS. And so that sort of comes with just memorizing these facts and knowing the disease processes. But you can sort of see how I worked through to get to FSGS based on the question. And that's typically how I have my students work through these questions. You know, take it a line at a time, work through a little piece at a time, and sort of narrow your differential as you go. And try I like to tell my students to try and have an idea of what you think the answer should be before you even look at them. And, you know, that may work for you, that may not. It really depends on your individual learning style. But that's how I would approach this question. All right, and with that, we'll take Taylor and have us go through question number 2.
That was great. So let's try the similar thing for practice question number 2. I'll tell you, when I first see this question, I immediately feel kind of sick to my stomach and think this is the longest vignette I have ever seen. And this will happen, especially for UWorld, and it can happen on the real thing. So I certainly don't want to waste my time, and I'm just going to go down to the last question. I'm going to think, what's the most appropriate next step in management of this patient's condition? So annoyingly, they didn't give me the condition in the question, but sometimes they do, so it can save a lot of time. But I read through the answer questions very quickly. Okay, cardiac cath, nitroglycerin, enalapril, statin, no change. Okay, so this is a management question. Probably something related with the heart, right? We're looking at ACE inhibitors, nitro, cardiac cath, statin. Okay, so I'm going to be paying special attention then to how bad this person's most likely heart condition is. Nitroglycerin, I feel like it's never often the answer because it's not, if you remember those medications that are in terms of reducing mortality, morbidity and mortality for heart patients, nitro is never really on there, but it can be a symptomatic relief. So I'm going to kind of pay attention to that. Enalapril, okay, let's see if there's any contraindications. It's a good medication for people to be on if they have heart problems. Stopping a statin, okay, maybe I want to be on the lookout for something that's, if there's maybe some side effects to the statin. And then no change is necessary, the world's most annoying answer choice. So these are, and you'll get very quick at this, thinking as you read these answer questions before you even get to the vignette, this is on your differential essentially. So A is terrible, heart disease where you're suspecting some kind of, coronary ischemia that could be improved with a cath. Is it symptomatic, needing nitroglycerin? Is it more medically directed, therapy targeting improved morbidity, mortality? Is it a statin side effect, or is it no change? Is it perfect management? So that's kind of already what I'm thinking. And then I get to the beginning of this really long vignette, and I think, okay, 56-year-old Black male. So they've already given us some information about his age. He's got some cough, trouble sleeping, 6 weeks. So it's not, sudden crushing chest pain that just started 2 hours ago. Exercise tolerance has decreased recently. Used to be able to walk 8 blocks, now become short of breath. Cough, clear sputum, worse lying down, shortness of breath, better with sticking a pillow under his head. This sounds like every patient that comes to get anesthesia at MGH. So I'm already sort of thinking about, this is a person with a lot of most likely cardiac comorbidities. I'm sort of already, that's on my radar. Luckily, no current chest pain, no fever, no wheezing. And lo and behold, he does have every risk factor. He's got CAD, hypertension, type 2 diabetes. Okay, they mentioned his medications he's on, metoprolol, statin, and metformin. Some of you may already be thinking, what is this person missing? Typically you'll see an ACE or an ARB, an ACE inhibitor or an ARB in this medication regimen, but maybe there's a reason he's not on it. I just kind of keep that in the back of my mind. Vitals are always useful. Respiratory rate's a little high, blood pressure's a little high, but nothing crazy. Neurologic's fine, cardiac auscultation is fine, pulmonary has some mild bibasilar inspiratory crackles. Okay, that sounds kind of fluid overloady, perhaps. And then we've got some left ventricular hypertrophy. I will say, sometimes, Sana, I don't know about you, sometimes with these really long vignettes, I often notice that the most helpful information is sort of in the 2 or 3 sentences before the question.
Oh, definitely.
Right? Here we could have we probably should have read all of it, but we could have gotten a much better idea. EKG shows left ventricular hypertrophy, and we've got a left ventricular EF of 45%. So how about this? What are all of you, and feel free to write in the question box, we're the only ones who see it, or in the chat box, what do you think this guy has? So you hear about this left ventricular ejection fraction of 45%. What are you worried about that he has?
Nice. Got a couple of people already saying the right answer. Wonderful.
Good. So I see kind of left-sided heart failure, right? So left side of the heart is having a hard time and it's backing up into the lungs, giving you all of these pulmonary symptoms. Maybe eventually, if this continued, he'd have right-sided heart failure. So that's really kind of what we're worried about here. And some of you I've already picked up on this, that patients who have, reduced ejection fraction heart failure, or HFrEF, as we sometimes call it, really need to be on, a nice set of medications for their initial therapy. So these are going to be things like renin-angiotensin system inhibitors, whether that's an ACE or an ARB, beta blocker, and oftentimes diuretic therapy as well. So generally, you want everyone to be kind of on this magical mix. He is on metformin, which is great. He is on a statin too, which is helpful, especially with this history of diabetes. But really what you want to be doing in this person who's having kind of a subacute presentation, subacute worsening of heart function, kind of in this decompensated heart failure picture, you want to be maximizing his medical management. And I think it's hard to eliminate C. And that's kind of how I would approach this question. So again, when you have these long vignettes, reading the question sometimes can give you some information. Reading the answer choices, if that's something that you find helpful, I personally do, can give you a sense for what should be on your differential as you're reading the question. And then when you have these long vignettes, maybe don't just read the last question, but sort of read the last question and then go back a couple sentences, because you can often get that key. It's usually diagnostic or lab tests or EKG or echo or something like that that'll give you information, but still skim the rest of the vignette. Anything you would do differently, Sana, with this question?
No, I mean, I think that makes perfect sense to me. I mean, the big thing is really figuring out what are they getting at, I think, is the key here, right? So yes, they're talking about next steps in management, but here the essence of this question, if I had to boil it down into one line, is really just about what are the mortality saving medications in heart failure, right? That's what they're testing, that you know. They're testing that that using ACE inhibitors is a mortality proven benefit. And so really just trying to, obviously you won't have time to do this when you're taking the test, but really when you're taking your UWorld test, when you're going through the question blocks, trying to take a moment and be like, okay, what is the point of this question? What is this question trying to teach me? And using that when you move forward will make you that much faster the next time you see a question like this.